This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I am Mariana Parts, physical therapist and your host, and today I interview Dr. Lance Mabry to discuss the integration of diagnostic imaging into physical therapist scope of practice. Lance is a board-certified clinical specialist and a fellow of the American Academy of Orthopedic Manual Physical Therapists. Dr. Mabry retired from the U.S. Air Force and is an assistant professor at High Point University in North Carolina, where he teaches diagnostic imaging and physical therapy primary care. In our discussion, we talked about clinical utilization of diagnostic imaging by PTs, the three scope of practice levels, expansion of physical therapies to jurisdictional scope to include imaging referral, and how to advance the PT profession through the APTA and PT's efforts. So if you find this information valuable, I encourage you to subscribe to our channel, click on the notification bell to stay updated, give us a thumbs up, and share this episode with other clinicians you believe will benefit from our conversation. Thank you for tuning in, and I hope you enjoyed the show. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Fitter First, your first choice for the best Canadian-made rehab and fitness products since 1985.
Systems for PT, the do anything, anytime EMR. Systems for PT develops systems for clinics so you can focus on your patients. Go to systemsforpt.com to schedule a demo today. Hi Lance, welcome to PT Pro Talk. How are you today?
I'm doing wonderfully. How are you?
Doing awesome. Thank you. And so let's start just talking a little bit about yourself and your career. Let's talk a little bit about that so our listeners can get to know you a little bit.
Sure. So I'm Dr. Lance Mabry. I'm a retired Air Force physical therapist. I'm a board-certified orthopedic specialist, and I've completed a fellowship from the American Academy of Orthopedic Manual Physical Therapists. I'm currently an assistant professor at High Point University, where I teach in the primary care and diagnostic imaging curriculum.
Awesome. And I know that you've been teaching diagnostic imaging and primary care, how you just mentioned, and a lot of your research centers on how physical therapists are clinically utilizing diagnostic imaging, right? So can you tell us how you got interested in that space?
Yeah, I think, I think I got interested in diagnostic imaging reasonably early in my career, probably while I was still a student. I think, I went to school and they taught us the Ottawa ankle rules and Ottawa knee rules, and I'm pretty sure we all know those as therapists. But when you get to the clinic, the number of patients you have with acute ankle injuries or acute knee injuries are few. A lot of the stuff that we're seeing is more chronic. And I realized that, in a military setting, I was the one responsible for deciding who got imaging and who didn't. And there wasn't a whole lot of education in that space. Like when do you order imaging for something like chronic low back pain, or when do you not? So I also realized early on that I didn't have the skill set to communicate with radiologists through the referral process. And that's when I thought, well, shoot, this can be taught better, and this can be taught in a way that's more easily digestible for physical therapists. I really leaned into my ignorance in the space, and I had a great mentor in Mike Ross, who's a world-renowned physical therapist in the primary care space, diagnostic imaging, differential diagnosis. And he really helped to center me in that area. He helped me with my first few manuscripts to get my feet underneath me. And then since then, I've continued that work primarily in diagnostic imaging until it eventually led to a place in academia.
Yeah, and I feel like that's an area that we don't have that much people talking about it or discussing. So I think it's great that we are bringing all of that here so we can spread that to our listeners.
Yeah, I agree. I think that while diagnostic imaging and physical therapy is an evolving topic, and I think it's getting more excitement, especially now that there are 11 states where physical therapists can refer for imaging. I think that for a while it was a topic that wasn't given as much attention in the physical therapy profession as maybe it should. So yes, I think right now I'm probably a bit of an outlier in the physical therapy profession with my expertise in imaging, but I suspect over the next 1 or 2 decades, you're going to see a lot more physical therapists in that space, which is my hope. I mean, that's where the profession needs to go. It's where we need to evolve.
Yeah, absolutely. And in your recent paper in the Journal of Manual and Manipulative Therapy, you discussed the 3 scope of practice levels, right? Can you explain that to our audience?
Yeah, so we just published an article in the Journal of Manual and Manipulative Therapy. The editor-in-chief over there is Jean-Michel Brismé, who's absolutely brilliant. And it was an article we did where it was a survey-based study. We had roughly 6,000 participants in that study, which is probably one of the biggest ones that has been in the physical therapy profession. And really, we were trying to look at, how imaging was being practiced or imaging skills were being practiced in physical therapy with the idea of kind of advancing the jurisdictional scope. So your question was, what are the 3 scopes of practice? And the APTA House of Delegates voted on this and defined them very well. There's the professional scope of practice. That's what falls within the profession of physical therapy. So things like dry needling, spinal manipulation, diagnosis, direct access, all those things fall within our professional scope of practice. Things like surgery right now don't fall within the professional scope of practice. Then a subset of that is the jurisdictional scope of practice. So the jurisdictional scope of practice is whatever is allowed in your jurisdiction. So primarily that's at the state level. So as an example, dry needling is within the professional scope of practice, but I think in some states, like I want to say Washington, it's not allowed. Versus dry needling in North Carolina is allowed. So that's both within our professional and our jurisdictional scope of practice. And then the third scope of practice is personal scope of practice. And that's what any one individual physical therapist is trained and capable of providing well. So I'll stick with the example of dry needling. So dry needling is within the professional scope of practice for PT. It's within the jurisdictional scope of practice in North Carolina. We're allowed to do that due to a Supreme Court ruling. But I haven't been trained in dry needling. It's not something that I do, so it's not within my personal scope of practice. So even though it's legal in my state, I could get in trouble if I dry needled someone without additional training at this point. So I think that was kind of the idea behind our paper was, okay, now that these are defined, what can we do to advance this jurisdictional scope of practice? And the thought that we had is, well, physical therapists right now are probably doing everything but ordering the image, right? They're probably sending the patient back to the PCP. They're probably saying they need X-rays or MRIs. They're probably doing all the work, but they just can't take that administrative leap due to some of the restrictions out there. So our study, the first thing we had to define was, well, okay, if physical therapists are doing everything but referring for imaging, what is the everything but? We had to define that. So we got a panel of experts together. We came up with 9 skills that were associated with imaging referral. I don't know them all off the top of my head. I'd have to look at the list, but I think like triaging the patient to see if they're appropriate, using evidence-based guidelines, determining whether or not it's a risk benefit in this particular patient. If we're requesting imaging, suggesting an imaging modality like X-ray or MRI, reviewing the results, educating the patient, integrating the findings into the treatment plan. Maybe I didn't know all 9. And then the last one was if the findings are outside of the scope of practice, are we referring on to someone else? So essentially, we took those 9 skills and we surveyed the physical therapists out there, and we found that a very high percentage were performing these skills already. And I think there was somewhere between 20 and 30% of physical therapists were already performing all 9 of these skills routinely right now, which suggests that imaging practice is widespread in the physical therapist profession, and that should be supportive for state boards to ultimately pass these, pass the advancement of the jurisdictional scope to allow us to refer for imaging.
Because right now, if I understood it right, most states, they don't allow PTs to refer directly to our radiologists, right?
Yeah, that's a good question, and it's a more complicated answer than you'd think. So right now there are 11 states that explicitly allow physical therapist imaging referral. And again, I don't know if I know the list off the top of my head, but there's Wisconsin, Colorado, Utah, North Dakota, Arizona, Maryland, DC, New Jersey. I forget if I said Rhode Island, but there's 11 states that allow, West Virginia. There's 11 states that allow physical therapist imaging referral right now. There are only a handful that explicitly prohibit physical therapist imaging referral. So one of them is Georgia, that talks about it. It's explicitly written in their Practice Act. One of them in North Carolina, where it says that we can refer to a radiologist, but we cannot order imaging, which is kind of conflicting language. But the vast majority of states fall into this nebulous silent area where they neither say it is allowed, nor do they say it's prohibited. It's kind of ambiguous on what is allowed and what isn't. So I believe Illinois is one of those states, and you're seeing a lot of the research by Aaron Kyle coming out of there, where they're actually getting some imaging referrals set up for physical therapists. And I suspect that will be the first step in a lot of silent states, will be to start building the evidence base before they ultimately make that definition either at the board level or or through legislation.
Because then if they don't say explicitly, how PTs can actually act if nobody really knows, they'll probably be scared that they are not allowed to do and get in trouble, right?
Yeah. So no, I think that's an excellent point, and that actually builds on another paper we're writing. It's actually submitted right now to JMMT for review, and we essentially looked at whether how the level of jurisdictional authority ultimately plays out in physical therapist awareness of what's going on. So we compared states where imaging was allowed by legislation. So some of the states of example of that are Wisconsin and Utah. Wisconsin allows physical therapists per their PT Practice Act. Utah allows physical therapy imaging referral through their Radio Tech Practice Act, I want to say. And then we compared those to states where imaging is allowed via board rules or board opinions. And that would include, again, off the top of my head, Colorado, Maryland, New Jersey, DC, are all at the board rules level. And what we found was roughly 75% of physical therapists in states where legislation authorized imaging referral, roughly 75% of PTs were aware of that in states with legislation. But in those with board rules, that number dropped pretty dramatically. And I think the number was something like 25% of PTs where the imaging referral was authorized by board rules were aware of that. I think part of that is, the concern with the more we talk about it. Once things are in law, it's reasonably hard to change law. That is a long and protracted process. But I think once it's at a board rule level, I think we as a profession are hesitant to talk about it as much. Because that could easily be overturned by another board rule or potentially legislation. So it's a little bit less secure than legislation. And I think that the same thing is more than likely true of the silent states. I mean, you can imagine if a state neither explicitly allows nor explicitly prohibits imaging referral, if they are in fact silent, the ability to talk about it gets even more restricted. So it's almost like, well, we're allowed to order imaging because it's silent, but don't tell anyone. And because of that, I question if we're really going to see the masses change practice if we're leaning on jurisdictional scope being silent.
And when you say the board versus the state, So what would be like the difference? Can the board approve and the state don't approve, or how does that work?
Yeah, so ultimately, law trumps the board. So legislation, Practice Act, that trumps everything else. But practice is broad, right? I mean, you think about all the things we do as physical therapists. For legislation to cover all of those things, it would be very detailed, right? And law is written to be more broad brushstrokes, and oftentimes the state boards are asked for opinions on what it means, or on things that are left out. Think about things like, when professions change, or when the healthcare landscape changes, like we just went through COVID. There were things that were happening faster than legislation could keep up with. Usually for legislative changes, you're talking in an 8 to 10 year cycle for legislation to pass. So in the absence of legislation, board rules or board opinions are largely standing in as what is allowed in that space. Now, they may ultimately be overturned by law, but essentially the board will do that in the interim. And well, we saw that a little bit with, again, where rules are dictated by appointed boards. One of the famous ones that was in the newspaper recently was the student loan reimbursement that was decided by the Board of Education, right? So the Board of Education is not an elected position. They were appointed by the administration, and they said, okay, we're going to wipe away all these student loans, right? That's at a board level, and the lawmaking body, in this case Congress, said, well, wait a minute, no, that's our responsibility. We're going to take that back. So not largely different than what you'd see in the states, like the General Assembly in North Carolina and the state boards. The state boards are kind of filling in that space when clarity is needed.
And if the state determines something, the board can go against it. Is the law is superior?
Yes. Yeah. So law would trump what the board has to say. So if something was passed into law, the board couldn't go against it. Or if something was passed into law and something was already in the books at the board level, whatever the law says would now supersede what's determined at the board.
And then if the state doesn't say anything and the board says we can order imaging, then you can order imaging until something changes in the law. Okay.
Yeah, so that's, if you actually look at the Practice Act in Colorado and North Carolina as two examples, right? Colorado explicitly allows imaging referral. North Carolina explicitly prohibits imaging being ordered by PTs. The Practice Acts read exactly the same, and the Practice Acts both read something to the effect of, physical therapists cannot, convey roentgen rays on patients, but that's not what we're doing. We're not actually operating the X-ray unit. We just want to refer patients for imaging. So it's not at the Practice Act level that things are prohibited. It's when you start digging into the board rules. So in Colorado, you dig into the board rules and it says something to the effect that physical therapists can refer for imaging to include MRI or advanced imaging, something to that effect. And again, on the North Carolina side, the board rules say physical therapists can refer to a radiologist, but we can't order imaging, which is, again, it's a bit confusing. But so oftentimes you'll see a lot of what we can do, a lot of what's in our jurisdictional scope is being determined by state boards and not necessarily legislation.
Mm-hmm. And I was reading on your paper something about the insurance companies reimbursing for imaging when directly referred by physical therapists. So is that like common in your experience? If the PTs are allowed to do the referral, usually the insurance will cover or reimburse.
Yeah, the evidence we're seeing on that has overwhelmingly said 100% reimbursement. So that's from the Kyle et al. Article. There was a oh goodness, I don't want to mess up his name, but I want to say it's something like Trafauner et al. Also said 100% reimbursement. And then there was also an interesting survey study was done in Wisconsin, and they surveyed physical therapists, and physical therapists said they were concerned that imaging that they ordered wouldn't be reimbursed. But then they were further asked if any of the images that they ordered were ever declined reimbursement. And they said, no, the stuff that we're ordering is getting reimbursed. So it seems that there's a fear that imaging won't get reimbursed, but that it's not actually playing out in reality. And then the other thing I would say is while we all care about our patients, right? I think that is the reimbursement of imaging is not necessarily our fight to have. So if you think about, when the primary care provider refers a patient to physical therapy, if that therapy isn't reimbursed, the MDs aren't all marching on the Capitol for us, right? That's our responsibility to get the imaging reimbursed, to engage with insurance companies and things like that. It's our responsibility to refer the patient for imaging, and then it's the imaging center's responsibility to work that into the patient's, insurance. So, I think sometimes we find roadblocks for ourselves in the profession where we shouldn't find roadblocks, right? The first step is get the patient the imaging they need, right? And the radiology clinic, I promise you, they have a whole staff of people that are engaging with those insurers. I haven't seen too many radiologists on a street corner, begging for money. They're getting that insurance money. So that's what they're in place to do.
Yeah, I think it's just the big part of education to just letting the patients know so they are not as afraid also to go and seek the imaging for fear of reimbursement. But just the PTs need to have the basic knowledge that, yes, it is usually reimbursed. So I just feel like you just need so much education because a lot of times we don't know those things that are different from our day-to-day practice. And because of ignorance, a lot of PTs probably scared of just ordering because the patient's going to have pushback from the patient saying that they're not going to, they don't want to spend that money if they can go to their insurance.
Well, and there's a cultural inertia thing with this, right? I mean, even in states that explicitly allow for imaging referral, for decades, physical therapists have not been ordering imaging, and now we can. So there's a bit of a cultural inertia issue where, someone needs to step out and be the first clinic to set these up, and someone needs to step out and be the first physical therapist at their clinic to say, this is what we're going to do. And too many therapists I hear say things like, oh, well, we don't have access to the imaging. Well, why not? Why don't you have access to the imaging? Why aren't you connected to the EMR that can look at it? And if you're a private practice clinic, why aren't you asking the patients to bring in the CDs? It's a free medical transfer. The CDs are free for the patients. I'm looking at even a pro bono clinic in a socioeconomically depressed populace. I'm looking at imaging for all of my patients. I tell them to bring them in. They're happy to do that. I'm taking a look at them and seeing what's there and what the radiologist is saying and how that impacts their care or maybe their prognosis. So I think that part of it is saying, okay, well, now that we have this responsibility, I think we need people to step up and say, I'm going to be the one that gets this in place. And it's interesting, in talking to Aaron Kyle out of Illinois, he said that radiology centers, especially privately owned radiology centers, are really thirsty for another referral source, just like a lot of physical therapy clinics are. So, if you're a clinic that's in a state that's allowed to order, a lot of times just reaching out to a private practice radiology clinic and saying, hey, I have a group of providers here that want to refer to your clinic. How do we set that up? And, they probably have the ordering script or the electronic pathways to get those orders in. They have the team there in place to get the imaging insurance reimbursed, and they're happy to help you navigate that system. But it takes somebody picking up the phone and making that call.
And knowing that they can, I think that's the big thing. As you said, a lot of PTs are not aware. So other than getting approved, you got to spread the word between PTs and make this a common practice and get those relationships established with radiologists and make those advancements, right?
Yeah, that's absolutely right. And that's part of the thing that we talk about in our upcoming paper that, again, it's in review now. But, the APTA can do as best they can to spread that word, but it really comes down to the state board. The state board, many of them have jurisprudence examinations. I think where we can be really successful is having the APTA engaging the state boards and making sure that in states where imaging is allowed, that is an explicit question or within the jurisprudence examination. Obviously there's other ways the state board can get that out there through email and other pathways. I know not every state has a jurisprudence exam every year. So some states have a jurisprudence exam every couple of years for license renewal. I believe others just have you take the exam on the front end and then you don't have to take it on the back end. So there needs to be a pathway to get the jurisdictional scope clarified and the organization that has access to all the physical therapists is the state board.
And do you think that the APTA they are playing on this game? And do you feel like the physical therapists can help make an impact as well? Is there anything that we can do as a profession?
Oh yeah, so the APTA has been playing huge roles in this, and I too often I hear people complain about the APTA. I'll admit that 10 years ago I was probably one of them, and they talk about all the things that the APTA isn't doing, and then now the more involved I am with the APTA, I'll hear these complaints and people are saying, "Oh, the APTA isn't doing this," and I'm like, "Well, actually, they are. Like, let me show you all the things the APTA is doing in that regard." So, in regards to imaging. We've had a number of states that have just gotten imaging referral in the last year or two. I ran through them before, but the ones that just recently passed were Rhode Island, West Virginia, North Dakota, Arizona, off the top of my head. And I know there are other states that are working on this. However, the APTA is overwhelmingly a volunteer organization. So everything I do, I'm the key legislative contact for North Carolina District 8. I'm the Federal Affairs Liaison for the state of North Carolina for the APTA. I'm engaging with senators and representatives regularly, and I don't get paid anything for that. And that's true of the overwhelming majority of APTA members, is those that are engaging are doing it volunteer time between patients or during their lunch hours. Really, we need other PTs to help us get this passed. So if someone's out there listening and they want to get imaging passed in their state, reach out to the state chapter. You might be the voice that they can kind of lean on to kind of get this moving. And then one thing I would recommend is, this is free for APTA members, is everybody should be signing up for the APTA Advocacy Network. That's something you can Google, the APTA Advocacy Network. They will send you emails when bills are about to pass or need votes, and they might need you to email a senator or representative. That's an easy way to kind of get a pulse on what's going on with legislation, both nationwide and within the state.
Awesome. And you were mentioning before that the PTs are already performing this imaging skills, right, to be able to refer to a radiologist. So that's something that I think it's important to just mention, because sometimes I think people are just scared of not knowing what to do. So in your opinion, the PTs are entirely qualified to do that?
So I think we as PTs sometimes create roadblocks that don't exist to our advancement. And one of the things I'll hear in relation to imaging is, every physical therapist needs to have, this education, or every physical therapist needs to have this or that. And no, that's not true at all. Not every physician performs surgery, but yet, every physician, at least as far as the rules, is allowed to perform surgery. It's just that those that's within their personal scope of practice, they either will or won't, right? So same thing's true, right? Like, not every physical therapist is performing spinal manipulation. Not every physical therapist is performing dry needling. And even if it's legal in your state, we talked about before, if I dry needled someone today, without getting more advanced training, I could very easily lose my license at the state board level because while it's legal in my state, it's not within my personal scope of practice because I haven't polished that skill set. So when we saw, and I forget the exact number, but it was somewhere in the 20s, I don't know, 23 or 28% of physical therapists reported doing all 9 of those imaging skills routinely right now today. What that tells you is that is an overwhelming number of PTs that are interacting with imaging in these various ways, and they're doing it right now. So I'd be willing to bet that not 28% of physical therapists are performing spinal manipulation. I'd be willing to bet that not 28% are performing dry needling, but yet these are overwhelmingly allowed throughout the United States. So, especially when you start thinking about different practice settings, right? So manipulation might happen more in an outpatient setting versus maybe an acute care setting, as an example. So I think that, we have to understand that there are already PTs that are practicing at this level. If somebody is not practicing at this level currently, that's not a big deal. That just means that they need to spin up their skill set and spin up their education, but that shouldn't hold back the rest of the profession from getting the jurisdictional scope that we have already earned.
Yes. And you have a military background, right? So you were trained, and we know that that's different in the military. So do you feel your knowledge was very different because of that background? Or do you feel like the current DPT education is sufficient to allow the patients? Because I saw that your research was now in the military. So I assume that all the PTs have that knowledge. But do you feel that is very different, your background versus the normal DPT education?
Yeah, so I think that's a good question. So let's start off with this. In the Air Force, the overwhelming majority of physical therapists are hired through the civilian hiring process. So I think the Air Force gets roughly 2 PTs a year that go through U.S. Army Baylor and are trained at a military DPT program. But overwhelmingly, we're getting them from civilian clinics or from civilian DPT programs, excuse me. So to say that the military has some sort of secret sauce in training, I think is a bit of a misnomer. And it's one of the things that came up in the Boyles, Rob Boyles, Bob Boyles, he's a brilliant guy. He's a friend of mine. He had the article in 2011 on diagnostic imaging that's very heavily cited. And there's one sentence in there that talks about some of the continuing education that physical therapists get in the military. And I think it was a sentence. I think if we could cut that sentence out of that article, I think it would do the practice a lot of good, because people keep saying that the military has this special training. We have this special training. We don't have any special training. I went to Army Baylor where we learned about the auto ankle rules, auto knee rules, just like all the civilian clinics were. Really what it came down to is when I got to practice, now we are practicing it every day, right? So the civilian PTs out there, the civilian PT programs, they are getting this imaging education, but then they hit the clinic and they're either prohibited from using it or they're not using it for cultural inertia or other reasons. And just like anything else, that skill set wanes, right? So today, I am not a pediatric physical therapist, but when I was a new grad, I probably knew more about pediatric physical therapy than I do today, right? But I didn't use that skill and it waned over time. So no, I would say physical therapists in the military do not get any kind of special training. There's no secret sauce. There's no secret process. We are getting the same training. We're accredited by the exact same body, CAPTI, that accredits the civilian programs. It's just that when we get to practice, we're actually not only able to use these skills, but we're expected to use these skills. And if and that's a skill set just like anything else. As you practice it, it continues to strengthen and evolve.
Yeah, you just get better at it. Like when you're a new grad, you don't know a lot of things, so you start practicing and getting used to getting experience and getting better at it. But when you don't get to practice, then you forget everything about it.
Oh yeah. Well, and you look too at, some of our research, the one that came out in 2022 with JMMT, will show that, physical therapists that are residency or fellowship trained, or those that are board certified, they're all interacting with imaging more often than those that aren't. And that would make sense. When you look at the description of specialty practice, when you look at the board specialization tests, part of that are imaging questions. In fact, part of the NPTE are imaging questions. Within all of the clinical residencies, now there's some that aren't clinical residencies like faculty. I think there's a faculty residency. But within the clinical residencies and the clinical fellowships, diagnostic imaging education is woven into all of them. So I think there's no surprise, when you look at one of the main things that was added when we went from a master's of physical therapy to a doctorate of physical therapy was this mandate on diagnostic imaging education. I think that makes sense why we see DPTs interacting with imaging skills more than their MPT and their BPT counterparts. And I think, again, it makes sense why we're seeing those that are board certified, residency and fellowship trained are interacting with imaging more as well.
And I think that's a big difference between physicians and PTs ordering the imaging, because we are treating those patients. We know who is responding, who is not. It might be something there because the physician is going to see them really quickly and is not going to have that deep vision of like the patient, and might be ordering imaging for everybody, being afraid of being sued or for whatever reason, standard. You're going to get an x-ray, and we know all the negative effects of that instead of just ordering when it's really necessary to order. And I think the PT is going to have a way better view of the patient and the need of the patient to really order the exam when it's really needed, not just for everybody else or for people that have pain for a couple months and are not improving, but they're also not doing anything to improve. So I think that's a big difference that could have a huge impact on the healthcare system.
Yeah, no, I think so. You're touching on the concept of appropriateness. So, is the image appropriate or is it not? And a lot of times, the benchmark that's measured against is the American College of Radiology appropriateness criteria. So, you can review a case and you can look at, the patient is presenting with these symptoms, and these symptoms, and you can bounce that off the American College of Radiology appropriateness criteria and see, yes, this image was justified or not. And I think a lot of times we hear that imaging is overutilized, when in reality, if you actually dig into that a little bit deeper, that's not the case. And when you start talking to people that are in this space that are really knowledgeable, like Chuck Hazel is the former Imaging SIG president, what you'll hear a lot of us say is that imaging isn't overutilized, it's misutilized. A key example of this is the Jenkins et al. Article that came out in Spine Journal. They not only looked at images that were ordered, but they also looked at images that weren't ordered. And what they found was, roughly, I think it was 1 in 3 images that were ordered were unnecessary. So, the appropriateness of imaging ordered was in the 60-ish% range. And then you say, wow, one out of 3 is overutilization, right? They're ordering stuff that doesn't need to be done. But then they looked at it in patients that needed imaging. So they had, concerns for cancer or red flags or other things that the clinician was identifying. But yet they held back the imaging referral in roughly 2 out of 3 of those patients. So yes, 1 out of 3 images ordered were overutilized, but 2 out of 3 cases where the patient really needed imaging, it was never ordered. So you would call that underutilization. So the reality is the physicians aren't getting trained in this space a lot of times. It's not their fault. They're much better at us at the pharmaceutical side. They're much better at us in the lab side and various other things. But the imaging side, we are just simply better than they are in that space. And, that actually shakes out when you look at, you talked before about the difference between the military and the civilian side. But when you look at some of the research that's coming out on physical therapist appropriateness when we order imaging, that's been done both in the civilian and the military side. And essentially what we're finding is somewhere in the 80-ish to 90-ish% range we are appropriate, where somewhere in the 60-ish% range is where the physicians are. And that was done, I think Traferner, again, was one of those civilian clinic. Kyle et al. Was a civilian clinic. I think that's also Moore et al. And Crow et al. Those were on the military side. So we are doing this better, and we're doing this better right now. And sure, is there room for growth? Yes. But even so, right now, today, we're already doing this better than our counterparts. And for those that are against imaging referral because they believe too much imaging is being ordered, this should be your battle cry for us to get imaging, right? We're ordering it more appropriately. You should be the ones championing that this comes to PT responsibilities.
Yes, absolutely. And I think that we also know the risk benefit, because we get the patients when they come out of the imaging from the doctor's order, and they get the x-ray and they said that they have these bulging discs, they have degeneration and all of that. When like in the care, it doesn't make a lot of difference in a lot of the cases. So they just get the things on their mindset that they have that on their back. So I think that also negatively impacts the treatment. So knowing how to order when it's going to be more beneficial than not. Because if you just start making that a standard for all the patients, we see the negative effects on the patients when they come to the clinic, and they are, less willing to be open to the treatment because they already have on their minds that they don't have any space, they're bone on bone, they need surgery, and all of that stuff that we hear every day from our patients.
Yeah. I think that's when PTs see those things, it's important for us to lean into imaging and not lean out from imaging. So I think that too often as a profession, we have leaned out away from the imaging, and we've said things like, oh, the imaging doesn't matter, or this doesn't matter, or that's not what's going on, or whatever else. And what we are saying and what patients are hearing are oftentimes not the same thing. So what the patients are hearing is, so you don't know why, you don't know why I have pain, or you disagree with my doctor, and I've been seeing my doctor for 15 years, or other things. And then, that brings a level of fear and concern, and therefore exacerbating symptoms because of those things. I think instead, what we need to do as physical therapists, when you look at the literature, and we talk about this, I teach diagnostic imaging at Redefined Health Education. We have a course called Clinical Response to Imaging, where we talk about, engaging with our patients and having those conversations. When you look at the literature out there, when you take the time to explain the imaging findings to your patients and not necessarily diminish them, a lot of times that eliminates fear and it improves symptoms, it improves their function and decreases their pain. So yes, if you're a physical therapist that's frustrated by, the patient that got an imaging from primary care that maybe wasn't necessary, if that feels like, if I'm talking to you, and that sounds like many of you out there, I'm sure, we need to lean into that. Don't lean away from that. And I would encourage you to look into our classes, and there's ways you can make your patients better without changing your skill set at all.
Maybe going to those papers that tell you, I don't know now from the top of my head, but that tell you that a lot of people have the findings on the images, but they don't have pain necessarily. So it doesn't mean that that's going to be causing you the pain, right?
I think I would disagree with you there. I know there's a lot of studies that look at asymptomatics, but I think that if you, as you start digging into, and this is again part of our courses, but if you start digging into the literature on those, there really isn't anything that we do as clinicians where we don't have a comparison group. And I think that we need to start looking at studies where there's no comparison group, and we need to start questioning why those keep getting published. So if I was using the dry needling one, if I dry needled someone and they got better, and I said, oh, look, dry needling works, and I dry needled someone, they got better, and I dry needled someone, they got better, but there was never any placebo group, or there was never any comparison group. Well, how do we know they got better? They might have gotten better just because, or they might have gotten even more better if we didn't do anything at all. We could actually be slowing their progression. You need to have some sort of comparison. And when you look at the studies out there that will compare the asymptomatics to the symptomatics, there's a couple of them. Brinjicki et al. Does this brilliantly. They looked at a case control of symptomatics versus asymptomatics. Overwhelmingly, the findings on MRI and CT in the symptomatics were much higher than those in the asymptomatics. So I think that we need to take these, if we as clinicians want to talk about the asymptomatic studies and we want to talk about them more than the case control studies where they actually include the symptomatics, I think that shows potentially some underlying bias in our opinions on that. And I think that we need to get a better understanding of what else is out there that actually has a comparison group.
Mm-hmm. And how would you educate our patients on reducing their fears when they have those findings on the image? How would you approach them?
Yeah, so that's a great question. So one of the things is I don't recommend diminishing what's on there, right? So I mean, if a patient has anterior hip pain and they have a labrum tear, that labrum tear could very well be contributing to their symptoms. I think too quick we as physical therapists jump on the, labrum tears are asymptomatics in X number of percentage of patients because of the study. Well, okay, but asymptomatics are not walking into my clinic, right? I don't think there's a lot of clinics out there that are inundated with patients that don't have symptoms. So why are we talking about them so much? I don't understand why we focus on that. I think that, the patients in front of you right now, they have pain. And I think that by talking about asymptomatics, this is a word that Harmony Lee Grace Lee helped me with. She said, essentially, we're devalidating their symptoms. By talking about asymptomatics, we're devalidating their symptoms. We are invalidating their symptoms. We are not listening to their experience. So the first thing is okay, is it truly not a pain generator? If the patient has pain in their shoulder, but they have a hip labrum tear, okay, that's probably not a pain generator, right? But otherwise, we should be saying things like, hey, I see on the imaging that you have, a hip labral tear. The good news is a lot of these get better on their own just with some physical therapy. So these are things we see and we treat all the time, and these are things that we get better. So you are in the right place. I'm here to help you, right? So instead of having that argument over diagnosis and imaging and asymptomatics with a patient that really doesn't have the educational background to have that discussion, nor do they want to have that discussion, right? That's not a discussion they want to have. They just want to get better. So why are we, if we want to argue that amongst our physical therapy professionals, that's one thing we can do, but arguing that with the patient is not helpful.
And I think that a lot of times is like that structure finding on the images that they believe that's not going to change. I think that's a big issue because they have a rotator cuff tear or something, or something else, a labral tear, or just the bone-on-bone degeneration. So they think that is because it's structural, there is nothing that a conservative treatment can do for them. So I think that's one of the issues of like the imaging, that they have this mindset that when they go to therapy that they don't think that can be helpful because that's there on the image. So yeah, I need surgery. So they are not as open and willing to try the treatment because of those things as well. I think it's relevant is that the ones that are asymptomatic, they're not walking in our clinics. It's like that bias that I thought about a long time about that, having like a lumbar fusion. I was like, lumbar fusions, they don't work. Nobody gets better because the one that don't work, they're going to look for us. The one that work, they're not going to look for us. So it's the kind of like the same idea. For a long time, I was like, oh my gosh, you did fusion. It's not going to work because a lot of patients, because that's what we see in the clinic. So it's difficult sometimes to not have those bias in our practice because they are the patients that we are going to see, the ones that don't get better.
Yeah, it's absolutely correct. I mean, the ones that are walking through our door are the ones that haven't gotten better, and therefore it will bias us. So, one example I give of this is I think that childbirth, many people will agree, tends to be a painful experience, right? But if Jill has pain with childbirth, I'm not going to be like, well, Jill, why do you have pain with childbirth? Jane didn't have pain. So why are you having pain? Right. Well, that's cruel. And why would we say that? We would never say that. It sounds so absurd for it to come out of my mouth. That's how absurd it sounds to the patients when we say things like, oh, well, patients with degenerative disc disease are asymptomatic all the time. Well, thanks for letting me know, but my back hurts. Like, why are you telling me about other people that don't have back pain? Like, what's this conversation about? So, I think as physical therapists, we need to be showing these patients the imaging. There's a lot of things that are written in a radiology report that without context, the only thing the patients can do is just Google this stuff. And when you Google this stuff, it tends to say not very nice things. So, being able to show the patient the image, like, oh, you see this thing that says disc desiccation? Well, let's take a look at this. As we look at this, all you can see is just that this disc is a little bit of a different color. And that just means that there's a little bit less fluid there. So nothing to be too concerned about. These are things we see all the time. And these are things we can, work with you on to get better. So, having that image in front of the patient and being able to walk through that for the patient, you can really just watch that fear just erase from them as they, and as that fear goes away, that's where we start seeing the gains in function and the reductions in symptoms. So, a lot of times all they just need to hear reassurance. Oh, you're going to be okay. Like, there's nothing to worry about here. You're in the right place. And just having that reassurance is a lot of times what they need to just move on with their lives.
Yeah. And I think if the PTs are doing that job, they are ordering and they are the ones that are talking to the patient, is a completely different picture than getting the patient that already has all those fears coming from the doctor. And I think that's a very important distinction, I would say, like for this discussion of the ordering imagings that are not necessary and putting this fear on the patients, or SPTs ordering them when are necessary and not putting fear on the patient, but actually using those images in a useful way that's going to make a difference in the treatment, but not just ordering because you want to order and it's not going to be beneficial. You're just putting more fear. So I think that's very important to point out.
Well, I think the physicians and the primary care providers, I think they're in a tough spot, right? So, they talk about, how much time do they spend with their patient? And I've seen the contact time with the patient is often 5 minutes or less. I've seen 3 minutes in some studies. So they don't have a lot of time with their patients. And then on top of that, if you actually look at the research, it shows that the vast majority of physicians do not have a lot of training in musculoskeletal medicine. So, they have patients coming in with back pain or knee pain or shoulder pain. They don't know a lot about the space, and now they need to make the decisions on this patient in 2, 3, 5 minutes. An image is probably the best they have to offer at this point. And what makes this more challenging for them is that they can't unload it on us. They can't say, well, the physical therapist will make that decision, because in many states we're prohibited from making that decision. So, what we saw in the military is once physical, in the military, physical therapists could refer for imaging, and the primary care providers would say, oh, the patient has back pain, I'm going to send you to PT. And if you need an x-ray or an MRI, they'll figure it out. So it really allowed for that shared decision-making process where, the physicians could work in the space that they were maybe more comfortable. So every physician's different, but maybe they were, more comfortable at managing, diabetes, or, patients had various symptoms coming in. But when they would get somebody with musculoskeletal issues, because we were able to refer for imaging and various other things, they could refer to us with confidence and know that, if the patient needed something, we were going to get that for them. So, I think, getting to a point where we can do that regularly in the civilian sector, that's when we're going to start seeing that handoff and responsibility go from primary care to PTs where it belongs.
Yeah, I think it would be very beneficial to just put that more on the PTs, that responsibility Since we spend more time with the patients, we are rehabbing them, treating them. So I think that would be a very beneficial for the healthcare for the patient, and to take that off the physicians, because as you said, it's not really fair to be talking bad about them and all their practices when they don't have that much time, they don't have that much training. So it would be a great shift if it happens. I hope it happens.
Yeah.
Right.
Yep. Well, it's good. It's the APTAs doing their end on getting it changed at the state level. But it's on all the rest of us. Once it's changed in our state, it's on the rest of us to, contact those radiology clinics, get the EMR access, and actually put things into place.
Yeah. Okay. Well, great discussion, Lance. Before we transition to final questions, anything you want to add about everything we just talked about?
Sure. Well, I would love to add that, I am teaching diagnostic imaging through Redefine Health Education, and we are open to offering a discount code for your listeners. So it's the discount code is PT Pro Talk, all lowercase. And that will get $50 off our diagnostic imaging content. So if you want to look us up at Redefine Health Education, if you're interested in getting more polished in your imaging skills, we are here to help you. We have our next cohort is kicking off in September 20th, if you want to do it synchronously, or we also have asynchronous options.
Awesome. Katie was here in the last episode and mentioned that. So I appreciate you all, the work that you are all doing, and the discount you're offering. So hopefully you can spread the message to more PTs.
Absolutely.
And Lane, resource of information, anything in particular that you recommend to the audience?
So for resources, so those that are like textbooks, I would recommend Lynn McInnes's textbook, Fundamentals of Musculoskeletal Imaging. She's on her 5th edition now. I was lucky enough, she invited me to give some feedback on her lumbar chapter in this most recent edition. And frankly, Lynn's book is the best one I've seen out there. And one of the things I love about Lynn's book is it really focuses on which imaging views we need to order in terms of when we're getting x-rays. Too often I see therapists that just say things like, we need x-rays. Well, that's not enough. If we are doctorally trained musculoskeletal experts, we need to know what views we want. Do we want the sunrise? Do we want the obliques? Do we want the AP and the lateral? Do we want the tunnel view? And if so, why do we want those? So, her book goes through that wonderfully. It's excellently illustrated. For those that prefer to look at research, I mentioned these guys earlier, but Aaron Kyle et al., that's Keil. He has some great research into diagnostic imaging. Don Goss has great imaging publications. Mike Crowell out of the Army, he's also doing great things in research. And then obviously, myself, I would recommend my research also looks at diagnostic imaging quite a bit. Lance Mabry. So those would be resources I would look into. The other thing I'd suggest is looking into the imaging special interest group. It's part of the Academy of Orthopedic Physical Therapy, so the ortho section in APTA. If you are an ortho section member, it is free to join the imaging SIGs. So there's a lot of free webinars and free educational resources through there that I would recommend.
Awesome. And what would be the best advice you can give to clinicians that are starting their careers?
Sure. The best advice I can give to clinicians starting their careers. That's a great question. There's so many different pathways you can go on that, but the one I would recommend, the one thing I would recommend is to continue to advance your career. So, we're looking at some of the data. Residency trained physical therapists, per the research, are getting roughly $6,900 more than non-residency trained therapists. Fellowship trained therapists are roughly making $10,000 more than the non-fellowship trained therapists. The same's true with board certification. And when you look at the jobs demands research model of burnout, a lot of times it shows that the skill set that you get through residency and fellowship is leading to lower levels of burnout. There's a couple of articles on that as well. So, inevitably I hear PTs that are burnt out, and I'm on LinkedIn quite a bit. I can look back on their record, and the ones that are complaining of that the most, don't have the residency trained background, they don't have the fellowship background, there's board certification, and they're getting beat up, right? So that's one recommendation I would make, is continue to grow yourself. The other thing I would say is that there aren't too many full-time clinician physical therapists that have been a full-time clinician for 30 years, right? And if you look at, if you go to any physical therapy clinic and you look around and try to look for the 60-year-old clinical PTs, there aren't that many out there, right? So I think the reality is that most PTs will transition to something at some point, whether that's being a clinic owner, whether that's being a rehab director. Maybe they're in the clinic, but they're not in the clinic all the time, whether that's transitioning to academia or other things, or just leaving the profession overall. I think the reality is that most of us will have something next after our clinical selves. And inevitably, the people that I see that have the job opportunities available to them are those that have continued to develop themselves and, might present at conferences, or might publish research, or might, have a residency or board cert or fellowship training. And those that aren't doing these things find themselves on the outside, that there aren't as many job opportunities for them. So I would recommend people to continue, even if you love what you're doing today, continue to grow yourself, because at some point you may no longer love what you're doing and you might want other options.
Yeah, good. And final question, what personnel qualities and abilities that you think are important to be a successful PT?
Yeah, that's a great question. So what qualities or skills are essential for being a successful PT? We just saw a presentation at High Point University on teaching the neurodiverse student, and one of the things it talked about was that neurodiversity is an important part of the human cultural experience. That we have people on all ends of the spectrum as far as their personalities, and that there is no right or wrong way to be a human. And I think that's the first thing to understand. So I have a neurodiverse daughter. My daughter is autistic, and the more I lean into and learn about this space, I think there are some things that I might even be a bit some of my own traits I might be a bit spectrumy. So I think that we sometimes dichotomize things into being professional or not, like that, that interaction was professional or that interaction was unprofessional, or, this is the right way to do things and this is the wrong way to do things. And I think that there are so many variations with cultures and neurodiversity and everything else. I don't know if there is a right or wrong way. So, I might see an applicant that might struggle in the social setting, and you think, how are they going to be a good clinician, right? If they're going to struggle in a social setting, well, maybe that's not where they're going to be. Maybe they're going to be a PT researcher, and they're going to be in the lab, and they're going to be, writing the next big research article that changes the profession. So, I think that, instead of looking at, what skill sets, maybe people are lacking, I think that we need to just embrace the skill sets that people have, and then find an area that they can use that skill set to make them successful in the profession. And I think our profession is broad enough that we can make that happen for an array of different people. And I know that was a non-answer, but hopefully that still answered the question.
It is so broad, and we can do so many different things that I feel like everybody can probably find where they fit better with their skills. I think the ultimate goal, I guess, for everybody that gets in the profession is to make an impact, like help people have a better life. So if you find a way to help it doesn't really matter which way. I mean, you're using your skills to help
I agree.
improve quality of life.
Absolutely.
Lance, thank you so much for taking the time to be here to share all your knowledge in this very different topic that is not, we don't discuss that as often as we should, I think. And if people want to learn more about you or find about your work, your courses, where they can find you?
Yes. So as before, I'm teaching at Redefine Health. So if you want to look up Redefine Health Education, they can find me through there. I'm also on LinkedIn, or if they want to reach out to me at High Point University, my information is there.
Awesome. Well, thank you again for coming in here and sharing your knowledge and the discount code for our listeners. So I appreciate you. And yeah, I hope that we can help our profession to advance and share this information with other therapists.
Thank you so much for having me.